Thank you, everyone who came to the event, our panelists, and all of you. First off, just give me one moment here. Okay, awesome. Okay, so I would like to introduce you to Dr. Ling Cao. She graduated from the Beijing Medical University with an MD before getting her PhD at SUNY Albany, and is an associate professor in the College of Osteopathic Medicine. For the last decade, she has been investigating the neuroimmune mechanisms in peripheral nerve injury-induced neuropathic pain. She has established an active collaboration with the Pain Center at Mercy Hospital and has initiated an innovative interprofessional chronic pain education program that involves groups of UNE students from various health professions. She is also the recipient of a recent R01 grant from the NIH for her work. Thank you.
Thank you, Lindsay, for the nice introduction. I think there are a couple housekeeping things we need. Well, I should say hello for everyone and everyone in Biddeford campus. So there are a couple housekeeping things. One is to make sure your cell phone is on vibrate. And also you want, I know some of you have a class at 1 o'clock, so make sure you do that quietly when you're leaving. And the next thing is to be prepared to be shuffled around into different groups during our session. All right, so today's topic is really near to my heart. So I have been studying neuropathic pain for years, but it was more with mice. And my experience at a Mercy Pain Center from the last couple years was really eye-opening. So I learned a lot, and I hope that's true for you guys today and learn a lot of things. So we're mostly going to talk about chronic pain and the related addiction, advocacy issues. And if you actually think about chronic pain, it's not just one disease, one condition. It's so complex, and you can have two patients both with low back pain and have completely different causes and a different response to medications, and then they might have a different family social support and different, even insurance status could affect their management of chronic pain. And also, probably a lot of you know that for chronic pain, opiate is one of the major medications a lot of a pain patient receive. And you probably all heard about this opiate crisis in Maine and actually throughout the nation. And this new guideline from CDC for prescription, the dosage limit, which is, there's still a lot of debate out there, and we're probably going to touch on a little bit on that. Hopefully our discussion will make you start thinking about all these issues, and that even we might not have the concrete answer to you for a lot of questions. And because pain is so complex, and it really makes sense interprofessional management, having a team from different professions and using interdisciplinary management is really critical, important. So let's just take a poll. How many of you guys are from, let's see, PA program? Wow. And how many from a nursing program? Uh-oh. Probably all have class. PT program? All right, good. And PT is actually a very important component for pain management. And OT program? You're all busy. All right, social work program? All right, what did I miss? What other program? What is it?
Pharmacy.
Oh, yeah, right. The pharmacy program, sorry. Oh, boy. That's where you are. All right. So I don't know if we can hear Dave from a Biddeford campus. I don't know how many comp students are there. All right, great. All right. So Let's get things started, and then to help us understand chronic pain and addiction, these issues more with more knowledge, and then we have a very distinct panel participating in our discussion today. So let's start with Dr. Norris. All right, so for each panel, I'll give a little bit of introduction, and then they will talk a little bit about their experience, their training service experience in pain and addiction for about 10 minutes. And then later on, you guys are going to have 2 cases for you to discuss in the review. And then the panelists will help you to understand those cases and hopefully to understand more about chronic pain management and addiction issues. All right, so Dr. Norris is the osteopathic physician who graduated from Nova Southeastern University in Fort Lauderdale, Florida. She's board certified in addiction medicine, osteopathic family medicine, and obesity medicine. Dr. Norris is the medical director of the intensive outpatient program in the Macedon Clinic. And she has an outpatient practice in which she manages many conditions, including pain. She's the medical director for Greece Strait Recovery Center, which has facilities located in Portland, Lewiston, and Sanford. And also, Dr. Norris has her own office, Graceful Recovery, in Kennebunk. Dr. Norris is a clinical faculty member for UNE, is the president-elect for the Maine Osteopathic Association, and is the past editor-in-chief of a peer-reviewed national medical journal. Right. Thank you, Dr. Norris.
Is this sort of cordless? Okay, cool. So, a little more background. I practiced in Down East Maine in a rural area with a population of 2,700 people for the first 7 years of my career, and then relocated to southern Maine. And have you ever had one of those dreams where you're jumping up and down and trying to yell something important and there's no sound coming out and no one's listening to you and nobody hears you? About 4 years ago, the state of Maine decided that the really definitive way to manage opiate dependence was that they were going to make it as difficult as possible for people on Maine Care to receive prescriptions for chronic pain meds. If this sounds hauntingly familiar, it's because this is very similar to what the state of Maine is doing now, only instead of limiting payment and reimbursement for it, it's actually just making it illegal overall. At the time, and don't get me wrong, I love being able to say I told you so, but I would have been happily wrong in this case. At the time, we wrote a lot of legislators and said, you know, unless there's a concomitant increase in treatment for opioid dependence, you're going to have more people doing heroin. Like, yes, we think diversion is bad. Yes, we think there's too many opioids on the street. Mandate better risk management, but taking away people's pain meds is going to mean the people who are using them illicitly aren't going to get sober because there's no treatment, and the people who have a pain syndrome, which they can no longer treat, are going to move to heroin. And everyone patted my little head and thought it was really cute, but of course my opinion would be informed by working with people in recovery, so of course I'd think that. So currently, as you probably know, we have a heroin problem. And once again, the state is trying to basically make it illegal to prescribe controlled substances, actually specifically opioids. There's kind of a blank check on benzodiazepines and stimulants, which is a huge problem also. And if I seem like I'm on the warpath, it's because I just left my office where I had to have this conversation with people who have been high functioning and doing great and working for years because they're on meds which are literally now going to become illegal. So it is a frustrating situation. The other thing to bear in mind is that absolutely chronic pain is a multifaceted disease. It's not one, it's several. The things that contribute to who develops chronic pain. Now, how many think that what decides if someone's going to have chronic pain is whether or not they've been injured and had something hurt? Right, exactly. Good answer. The people who develop a syndrome of chronic pain are a function of their neurology, of their biology, of their trauma history, and unfortunately the same people who are hardwired to develop a chronic pain syndrome are people who have a lot neurologically in common with the people who have PTSD, i.e. the people who are likely to develop a substance use disorder more than the mainstream population who does not have a trauma history. This makes it a real mess, and I get that, and the worst possible thing you could do is just throw meds at everybody. And I'm a big believer in prevention, and I'm a big believer in risk management and harm reduction. That said, it's going to be pretty important for us to bear in mind when we're creating a new multidisciplinary pain model, what are the patient's resources? I worked at a 19-bed hospital for the first 7 years of my professional career, and I used to go to all these national conferences about managing chronic headache, managing chronic pain, and they would get into, we need CBT, and yes, we do, and that would be really ideal. They would get into, we need to have people learn biofeedback. They need to learn how to meditate. They need to do yoga. All of those things are good, and if it were Christmas every day, that's precisely what I would do. However, 19-bed hospitals in Down East Maine are rather notorious for their absence of biofeedback training or even of competent therapy. So it's real important. I've heard, not here, but I've heard in general some of the rhetoric in the statewide and national conversation implying that there's a blame situation happening for people who find themselves only on pain meds rather than the multidisciplinary approach that we all wish they were taking. Yes, I wish they would all eat a low-inflammatory diet. I wish they would all stop smoking. There's a lot of resources, including self-efficacy and empowerment, that many of the folks you'll encounter clinically are missing, and it's really important that you not discount that. The other thing that's very important is that there is no drug test and there is no dose requirement or morphine equivalence that will indicate somebody's level of functioning and somebody's level of independence. And I just had a guy get surgery because he lost 100 pounds and he needed, a penectomy. And he's on a ton of pain meds. I inherited him from somebody who had him on a ton of pain meds. So we're moving, he's doing everything. He's working full time. He's lost 100 pounds. He's a non-smoker. And the first thing the PA said to me when she did his pre-op was, wow, I saw his med list and he wasn't who I thought he'd be when I walked in. It's really important to remember that. It's important to remember that there is significant bias being directed towards people who are on opioid pain management that maybe isn't appropriate, and we do need to address this problem in a multidisciplinary way, but just like demonizing people with substance use disorder is not going to be the solution, neither is demonizing people who are already on a large amount of controlled substances and may need some extra help transitioning to something different. The final thing I want to remind everyone is that the CDC guidelines were supposed to be guidelines, they weren't supposed to be mandates, and that is a big part of the conversation that many clinicians in the area seem to have forgotten. They were also generated with the lens of substance use disorder and not necessarily pain management, and with very little input from the American Academy of Pain Medicine. Point to ponder when you're deciding whose gospel to listen to. Anyway, again, sorry I'm on the warpath. It's been that kind of a week. I think that's all for now.
Thank you, Dr. Norris. So actually, I forgot to mention, we have several distinct guests in our audience today. We actually have several chronic pain patients that's sitting at your table. So they will help you with the discussion. And you probably all realize that chronic pain is not only managed by the providers, and the patient input is very important. And most time we need a shared decision making for pain management. All right, so our next speaker is Professor Cali Foxx. I got to know Cali actually since I started working with the Mercy Pain Center, and she was really wonderful helping me with the interprofessional training for students. So Cali is a licensed clinical social work. She has She earned her psychology bachelor degree in psychology from Rutgers University and master's of social work from University of New England. She has been in the field of mental health and addiction since 1985. The focus of her clinical practice is co-occurring disorders of PTSD and substance use, child-parent attachment and bonding, and the family therapy. Cali has provided clinical and administrative supervision to students, master, and bachelor level clinicians and supervisors for 25 years. She's an assistant clinical professor and serves as director of field education at UNE School of Social Work.
Well, thank you. I actually don't have a lot more to say than what Dr. Norris already said. I think a lot of what she already talked about in terms of the profile of patients who will come to you is really pretty much the same kinds of things that I would have said. I think one of the things that's really important from my perspective as a social worker is that a lot of times people who have chronic pain often have been told over the years that they're crazy or that it's all in their head. And people who have trauma experience who hear that find it, they won't trust the provider, they won't trust what's going to be in their best interest, because all along for most people who are trauma survivors, they hear that message that they're crazy, that there's nothing wrong with them, and that nothing ever happened. So I think to perpetuate that is it's really criminal to perpetuate that for our patients. You know, the ACE study, thank goodness, has really demonstrated clinically to show that there is a very high correlation between people who have experienced trauma and people who experience unexplained pain. And I think that that is really an important thing to note, because in my many years of practice, I have to tell you that I have heard those stories over and over and over again, particularly from women clients who have what's called, you know, unnamed pain that doesn't seem to have any origin. They haven't had a particular kind of injury, and yet they have chronic pain, they have headaches, they have shoulder pain, they have back pain. And so I think it's just one of those things to keep in mind, that now we have some evidence that shows that that is indeed true. I also think that the whole idea of the way that pain works in the body and some of the ways in which we're learning to treat pain is very similar to the process of what happens to someone when they experience trauma. When someone is experiencing the triggers of being in pain, they'll recoil. They'll try to get away from the pain. They'll try to get away from the stimulus of pain. And so they begin to avoid a lot of things in their life, which makes their life very tiny. The same kinds of thing happen with people who experience trauma, that when they are traumatized, when they're re-traumatized, when they're triggered around things, they begin to recoil. They try to get away from that stimulus because it's so emotionally painful. And so when we, as practitioners, don't believe them, we don't provide them with enough information, we dismiss them, we act like they're just drug seeking, they get the same message over and over again, and they're less likely to seek out treatment from us, which is what they need. So it is a complex issue. A lot of what the trauma survivors I've worked with experience are things like chronic fatigue syndrome, fibromyalgia, pretty severe unexplained headaches. So I think that's probably about it.
Can I just check in and say, be sure to speak directly into your mic. Don't be afraid to pull it closer to you.
Okay, great. Thank you, Kelly. All right, so the last person in our panelist is Dr. Bates. Dr. Jessica Bates received her PharmD at Hudson University and completed a PGY1 residency in community pharmacy. She's a clinical faculty member at the UNE College of Pharmacy, and she spent much of her time at Penobscot Community Health Care in Bangor, where she provides clinical services in a variety of specialties, including anticoagulation, diabetes, and controlled substance stewardship. Right.
Thank you for the introduction. Can you all hear me? We're good. All right, so I guess my take on the whole thing differs a little bit, but I also agree with everything that's been said already about the history of trauma, and I just want to take a step back and make sure that when everybody here is talking about trauma, you know what type of trauma they're talking about, because I don't mean trauma like from a motor vehicle accident. So when I say trauma, what kind of things do you guys think of? What? Sexual abuse is a good example. Any other kinds of trauma? Have you all heard of ACEs before?
I just assumed that they did.
Okay. Well, I mean, I don't do a whole lot with this stuff, but if you want to go ahead and explain it, I think that would be really helpful. Just give people some background, because as a pharmacist, for example, like, I never thought of a lot of these things, but like when you go through social work school, like, these are the things that you're taught, but it's easily overlooked in a lot of other medical professions, so I think it's important to get a little more background.
It's wicked important.
Sure. So I'm happy to talk about that. I actually just assumed that everybody knew what the ACE study was. So the ACE study was done by two doctors, Robert Anda and Vincent Felitti. And these were two doctors who were part of a very large healthcare organization in California called Kaiser Permanente. Most of you have probably heard of them. And basically they began to look at the users of medical services, high-end users of medical services. But initially, the study actually started with a group of patients who were part of an obesity study. And what they found was that they found that at the end of the study, they had three groups of people. They had some patients who lost weight and kept the weight off. They had patients who lost weight and then gained back the same amount of weight. And then they had a third group of patients who not only lost weight, gained weight, but they gained more weight than they actually had to start with. And so they were really interested to know, why does this happen? And so they began to do some, I'm not going to get this right, but they began to look at the patient's history and their history of use of services. And what they discovered is that the patients who actually gained more weight than they had actually originally had some history of childhood trauma, whether it was sexual abuse, physical abuse, emotional abuse, loss of a parent who had been incarcerated, or some other kind of traumatic loss in their life, substance abuse of a parent. So given that that was what they found, they began to think about, okay, so if this is what's true about this group of patients, they wanted to know more about their high-end users of all of their members. And so they did one of the largest studies I believe that's ever been done of its kind, where they studied the records of 24,000 patients who were users of this healthcare management service. And these were primarily folks who were employed, primarily folks who were educated, primarily folks who were white, and I think it was an equal balance of men and women, and I think the age range was probably maybe 25 to 50. I can't remember exactly. So anyway, so they did the study, and what they discovered is that in this study, that they started to see patterns of patients who had who are high-end users of medical services that had a correlating history of childhood trauma, which they termed adverse childhood experiences. And so what they did was that they put together a 10-question survey for patients to look at that asked questions about how many of these adverse childhood experiences they actually had. So they were things like an incarcerated parent, a parent with substance abuse, witnessing domestic violence, physical, sexual, and emotional abuse. So they put this on a 10-question survey. They handed that out to patients. And what they discovered was that, by and large, the more adverse childhood experiences people had, the more likely they were to have chronic conditions, mental health conditions, substance abuse conditions, and other types of chronic physical conditions like heart disease that had no hereditary cause, asthma, diabetes, that all of these things seemed to be higher in patients who had more ACEs, adverse childhood experiences. So that's what the ACE study tells us, and you can read the study online. There's a website. You can read the whole study, and basically they have this grid that talks about how the impact of trauma has on the developing person, develop their brain development, their physical development from childhood, and how that impacts their continuing socialization throughout their lives. So you can imagine that the way that the brain develops, I'm going to make this up because I'm not a medical person at all.
I'll just go with it.
Okay, so the brain develops from the back up, right? So anytime that there's an impact of a traumatic experience for a child, it impacts the development of their brain. And so as the child is developing and there's things that happen that impact their development of their brain, it's going to affect their cognitive abilities, not necessarily to the extreme that they need special education or that kind of thing, but it's going to disrupt their cognitive abilities. It's going to affect their emotional well-being and their emotional ability. And all of that is going to impact their ability to be social in their lives, which is going to affect their peer relationships. So then we move forward, right? So that affects their peer relationships. It then affects their schooling. It affects their lives. It affects how they see themselves in the world. And what happens when people feel they feel different from other people? They don't have good social skills. They don't have good peer relationships. What happens? They sometimes find a substance that helps, right? So they start to use a drug, they start to use alcohol, they start to use tobacco, and that seems to help them cope. Well, guess what? That's part of what starts off those chronic health conditions. So all of that can be traced back to those adverse childhood experiences and the ability to find some ways to cope. Because when someone picks up a drink or a drug, they are not looking for a particular high. Someone who's experienced adverse childhood experiences of that kind of trauma, what happens is when they use drugs, when they use alcohol, when they engage in sexual behavior, when they're using tobacco, somewhere along that way, they begin to find something that works to help them avoid the trauma, something that helps them to forget, something that helps them to feel normal in the world. So is there anything you'd like to add to that?
No, you hit it out of the park.
Thank you.
Thank you.
Because I know I recently had all of this explained to me, and I think it's a really helpful thing to have a little bit of background, because a lot of the patients that I see, a lot of the patients that I review in my job as a clinical pharmacist do have these histories of high ACE scores and high incidence of childhood traumatic events. So I just wanted to make sure everybody was on the same page with that. So to get back to myself and kind of what I do, I'm in a unique clinical position, so I actually practice up in Bangor at Penobscot Community Healthcare, and then I'm teaching down here a few times a month for various different topics. And I also got very lucky because I got hired at the place where I did my residency, so I was able to carry forth a lot of work that I started previously and continue it this year. And one of those things is work around controlled substances, prescribing, access to medication-assisted therapies in my clinic, and ultimately helping to reduce the burden of controlled substances on the community that I work with. So my background with controlled substances primarily stems from a committee that I was involved in during my residency, which is termed the Controlled Substance Initiative, which I will refer to as CSI. And what that group does is it's an interdisciplinary group, so we have doctors, we have primary care providers, we have a pain specialist, we have social work, we have a nurse also. Trying to think if I'm missing anyone. Those are like the primary groups that we have, and we meet each week, and the pharmacy resident will work up the patient cases, and we usually get a lot of referrals from our primary care providers that say, hey, I inherited this patient and he's on a very high dose of opioids and I need some direction with how to handle this case. So we'll review the case and we'll give recommendations to the provider about how best to taper the patient, what other services, usually counseling, CBT, checking for a history of trauma, addiction, everything like that goes into this puzzle, so it kind of incorporates all of the pieces that have already been talked about. So that's primarily where my history is. It's something I've continued to work on this year in my new position. And then to go along with that, I've also been involved in the PMP stakeholder meetings in Augusta around the new rules and regulations for the new LD 1646 law, which has been referred to already. And so basically, for those of you who don't know, does everybody know what I'm talking about when I say LD 1646? Okay, so not everybody knows. Basically, the state of Maine is mandating lowering opioid doses ultimately for patients who are over 100 morphine milligram equivalents. So whatever opioid they're on, you have to convert it to morphine equivalents. And if you don't know how to do that, you can ask a pharmacist because we're really helpful when it comes to those things. And yeah, don't use methadone. Anyway, sorry. So that's one of the requirements, is that patients who are over that will either have to qualify for an exception or they'll have to be tapered down to a dose lower than 100 morphine milligram equivalent. So it's not mandating that people can't receive opioid prescriptions at all, it's just mandating that they're on a lower dose. And the reason for that is actually stems from the CDC guidelines, which I think you guys have been provided with a little handout, where they've found that doses over 100 significantly increase the risk for accidental overdose on opioid drugs, especially prescriptions. And overdose includes things like, yes, it includes death, but it also includes hospitalizations, respiratory depression, and those types of things. So I've been involved in those meetings, so I have a lot of background on the law if any of you are curious. I'm not going to get into all of the things that have been discussed there, but I do have a pretty strong background in that as well. And then as far as the substance use disorder piece of everything goes, PCHC recently received a grant for expanding our Suboxone prescribing abilities. So I've been working really closely with our different practices to help expand accessibility to Suboxone prescription. PCHC is very unique in the fact that we have integrated mental health, and we're also a federally qualified health center, so we can offer discounted services, including mental health and counseling, physical therapy, pharmacy services at a discounted or free price. So our clinic is very unique in those facets, but it has turned out to be a very, very helpful, collaboration between the different professions. So, and I think that's all I have for now.
All right, thank you, Jessica. So you guys already seen some live demonstration how interprofessional, all different professions learn about with each other on stage right here. So now it's your turn to do that. I think you guys already into a different group, and then you have the first case, and our panel members will walk around and maybe help you a little bit with the case. And also, please consult the patient guest here. All right, hopefully you all had sufficient time to review the case.
My son is one of your patients.
Just to make sure we're all on the same page, I'm asking for one volunteer to actually summarize the case. Anyone want volunteer?
Hi, my name is Paul. I'm a PA student, class of 2018. So our patient is a 51-year-old male who used to work as a pipe lifter. Can I super summarize it? Is that okay? Okay. He's had long history of chronic back pain. He's had a ton of surgery and multiple procedures in order to try and fix it, but he really hasn't. And the important thing is the last one he had, he was only supposed to wear a brace for the recovery after, but since then he's been wearing it for up to 10 years. He also has a history of narcolepsy, which prevents him from taking a lot of opioids or any pain medication because it, combination with narcolepsy, makes him sleepy. It doesn't really work. And he's lost a ton of weight in the past 10 years.
Maybe we'll have a social work students or pharmacy students talk about a little bit other history.
So what did we learn? So what we learned also perhaps from the social work standpoint, I'm a social work student, first year. I asked him what his thoughts were about the ACE score, and his feelings were that they didn't particularly apply to him. He mentioned that he had been injured in a work accident, and so that was what we were talking about in terms of how the ACE affected him or if he scored on it. We talked about whether or not he lived alone or if he had someone in the home supporting him. And tell me if you're wrong, if I'm wrong. But he mentioned that when he was going through the initial surgeries, he did live with his wife and children, and that he was home a lot, but was not able to do a lot with the children. And so that was a source of tension. And also that one of the children, there were a lot of concerns about that child. So he also mentioned that there was medication, he had medication in the home, and he was not necessarily aware that he should be asking for help in terms of remembering when to take it, what to take, and also to keep it safe from the children who might be interested in the medication for recreational usage. Now he lives, so the last surgery, he lived alone, correct? And now he lives with, he's been remarried, and that person is very supportive. Anything else? Okay. That's what we learned. That's what I was asking about.
Actually, a nice segue to our discussion for this case. So there are a couple questions, I'll ask you guys to talk about it, and then our panelists can chime in anytime. All right, so after you read the case, is there anything surprising to you? What did you learn from your group members during your discussion?
I thought it was really impressive that he's been able to handle his chronic pain without opioid medications, even though it is kind of a contraindication with his narcolepsy. I think he described his last surgery as, making the conscious decision to not take those medications anymore, and he described the pain as excruciating, and it was a really difficult time for him, but I think it shows a lot about his character, maybe not character, but I was just more impressed that he was able to maybe use other ways to manage his condition without pain medication.
So we have a question from Biddeford. I'm not sure I'm going to be able to pronounce this, but I was texted a question: did this case person have an issue with long-term use of benzodiazepines? Diazepines?
I guess I'll, before I was diagnosed with narcolepsy, you guys probably think this is crazy, but my doctor gave me Ambien because I was sleeping during the day, so they said they want to make sure I could sleep at night. Well, that's before I was diagnosed with narcolepsy. You have to go through a lot of tests to get diagnosed with narcolepsy. So that was the only sleeping aid I had. And you don't get a sleeping aid to a person that has narcolepsy and chronic pain. It was a different type of doctor. But
when Ernie comes to see you, how will you be able to help him?
If Ernie come into your office and ask for help, what would you do? What other questions you want to, ask him, and what other information you want to know?
I think our group, we brought up a really interesting point where how important it is to treat the person, not just the disease. And so I think in this case, it'd be important to reflect on the patient's goals and what outcomes he wants and how he's handling everything outside of the actual pharmaceutical interventions that he's going through. So, and just get to know him and what he's going through and try to offer some peace with that.
Thank you. Anyone else?
Going off of what Evan was sharing, talking about goals for the patient's goals for treatment, having that conversation, what sort of interventions he was looking for, what sort of scale of livable pain is what the target area is, because some people can function with a great deal of pain, and other people are looking for a higher, or like a full resolve. So kind of seeing what that discussion between the two.
Can I add on to that?
Thank you. Yeah, sure.
Over here. Over here.
Yeah.
Okay. I think that's a really good point to make, because a lot of the patients come in with an expectation that they're going to leave your office pain-free, or that eventually whatever treatment option you're giving them, pharmacologically, non-pharmacologically, whatever it is, that eventually they might be pain-free. So it's important to set realistic expectations about functionality versus complete pain relief. So I think that that is a very, very good point and an important conversation to have with every single chronic pain patient.
Great.
Wrong shoes, wrong shoes.
We just got a text from Biddeford. What other alternatives have I used in the past? I want to back up a little about the medication thing and the quality of life. With narcolepsy, in my last surgery, I was on opioids. And with narcolepsy, I was sleeping all the time. And that was before I was diagnosed with narcolepsy. I took it upon myself to say, hey, I don't have a life right now. Yeah, I still have chronic pain, but I am sleeping all the time. So that's when I cold turkeyed it. And don't cold turkey stuff like that. It's not good. But so the other question that Biddeford has, what are the alternatives? The alternative I have, and I have to use because I can't do any opioid use, is Advil, Tylenol, any NSAIDs, but I have to make sure that I eat or I drink milk or something, and as I stated, I can't eat that much at once. I have my diet brace on. I do use a lot of ice. I'll do, like after today, I'll go home, recline, and I call sitting on ice. That's the only thing that calms the, it's not a spasm, it's just I don't want it to get inflamed. That's like physical therapy. It's hard when I'm not supposed to move from my hips to my armpits. So I got my legs and I got my arms. Well, I don't know if it's because of the medication I'm on, but they're exhausted all the time. I can't do much physical therapy because I'm tired. I did build myself a recumbent bike so I can bike. But for a person that lives with chronic pain, it's hard to get the PT or OT to slow it down to where we progress for our body. We don't progress for an athlete that's going to run a mile, because I can't even walk a mile. So stuff like that. And my group members always say that to me. As PT, I can't try it anymore because I'm scared. They overlook my normal. Thank you.
My experience with chronic pain and physical therapy is that they treat us like Olympic athletes. It seems that they are taught that, okay, we've got a lumbar problem, this is how we go after that lumbar problem. Well, I had a therapist that said, okay, Dale, just get right up and jump up on that exercise and let's see what you can do. And I looked at him and I says, well, I haven't been on a bicycle in 23 years. That's how long I've been in chronic pain. I haven't jumped at all in 23 years. And I didn't even know if I could pedal myself twice around the pedals. And yet, this person was bound and determined that that was something I was going to do because that's the protocol for lower back pain. It's not. You have to tailor your program to that individual person. You really need to sit down and make sure that you understand everything about that person before you can make any type of judgment at all.
Dr. Norris.
One of the things that I ran into, I've worked in many different areas of the state and in West Virginia, is did we wind up having any PT people in here? It was like, well, when you think of a physical therapy person, what do you think of? Like if you were going to do the cartoon of a physical therapist, it would be kind of an athletic person, right? Like there's a reason people become interested in PT. There's a lot of reasons. I've had many people who have never exercised ever, and they are given a handout when they go to PT of, this is the thing, now go home and do this and really be paying attention to engaging your core. And that's not bad advice, but we have to think about what people are able to implement and what they're able to understand. If you've never ever done anything athletic and somehow, well, you really want to be focusing on your medius and not your maximus when you're doing these squats because it'll give you a different stability of your... I have found that it's extremely important when I'm sending people to PT to know who I'm sending it to, or if nothing else, spell out home exercise program to patient competency and patient capability. That yes, not everyone is going to be doing a 30-second plank. Not everybody is going to be doing, everyone can do yoga, but not everyone can be doing lotus position on day one. That's a very important part of communication as any kind of clinician, particularly in light of many reimbursement things reinforce use of modalities. We use ultrasound, we use e-stim, we use any of that stuff. And then the patient uses up their 2 main care covered PT visits and now they're done. And they're no better off because they needed tools they could bring home. They didn't need someone to wand at them. Not that there's anything wrong with that, but it's not a good use of your time. But it is, I cannot overemphasize what this gentleman is saying, is that often you'll have patients say, well, and then I went to PT and that didn't work. It's like, well, okay, so tell me what that was. Show me the exercises you learned. Well, I got a handout, I didn't do them. Okay, so the idea was you were gonna do them. I mean, people feel disempowered, they feel abandoned, they're not gonna go home and, I like an inspirational YouTube as much as the next person, but not everyone's gonna go home and train for the Boston Marathon. Many people have logistical and other reasons that they can't do that, and we need to bear that in mind and be respectful to that.
Yes, and I just, to add on to that, I also think it's important to remember that change is hard. Part of what, part of living with chronic pain, it may be about we want them to do well, we want them to be able to use PT, we want them to be able to use medication, all those kinds of things. But sometimes it can require a lifestyle change that they've never had to do before, or they don't know how to do it, they don't have any support to do. So it's important as you're looking at some of these patients, or any of your patients that are looking at a lifestyle change, that it's not about being non-compliant. It's really about lifestyle change is hard, and people have to have motivation to do that, and they need support in order to be able to make those kinds of changes in their life.
And belief that they can do it.
And belief that they can do it. Yep. It's also, the other thing that I just wanted to mention is about about poverty. Dr. Norris was just talking about patients who have main care. If you have 2 main care visits and all they're getting is a handout to go home with, think about what that might be like. It's kind of dismissive almost to the patient, and it's because they live in poverty that's all they get, right?
Anyone want to chime in?
I think it should matter if somebody is coming in when they first got injured, and if you're seeing somebody like Ernie or Dale or myself that we've been dealing with chronic pain for 10 years or 15 years, there's been a lot of medications that I've tried and got off of, and And I don't even remember all the things that I had been on. But I went to PT a little over a year ago, and I was able to do everything that she wanted me to do. Because I'm stupid and I'll push myself to do everything because I'm just that kind of person. Unfortunately, I wasn't cleaning my house. I wasn't doing any laundry. I wasn't doing anything because I had to sacrifice what do I want to give up to do something else. And my life has always seemed to be that way because I live alone. So you have to kind of look at that bigger picture to see where we came from and what we were like before to where we are now, right? I can walk a mile once a week. If I try to walk a mile 4 times a week, well, I have to give up something to get there. And I can take more medication, but what are you people gonna do when I go in and say, yeah, I wanna be able to walk 5 times a week, I need you to triple my Vicodin. Are you gonna do that? No, you're gonna call me drug seeking, take away the little bit that I get, now I can't even walk once. So I have a different situation as Ernie or Dale. We want to take the least amount of medication we can and still have the most life. And a lot of times we just restrict it. To me, this is my big outing for the week. I haven't done much before this, and I'm not going to do too much afterwards because someone's going to clean my toilet when I get home. It's going to be me. Right? So you have to look at that big picture, I think. And, you know, at what stage are these people at? If someone's been dealing with chronic pain for 20 years, they've probably already been there and they probably have given up hope a little bit. So you have to have a little bit of patience. And seeing a counselor or a psychiatrist, those have to be integrated into your stuff, which I do. I see a counselor, a psychiatrist, 2 different primary care physicians. Those are the people that keep me moving and having friends like Ernie and Dale and Ken, because they're people that can relate to our situation. We're guys, we're supposed to be tough, you know, we're expected to do the things that guys do. And we get feeling pretty bad about ourselves when we realize we can't do those things. So you need a bigger support system just instead of just physical therapy. Because I'll bench press 50, 100 pounds 10 times if you want me to. I'll suffer for it later, but I'm stupid like that.
Anybody want to respond to that?
Seems like we're hearing from the chronic pain people, and I'm one of them, but I just wanted to give my feedback on the PT, because I was a professional dancer for 30 years, and my pain started with a failed surgery on my foot and led to 4 other surgeries. And I have had physical therapy be awful, and I have had it been really wonderful. What I haven't had is the surgeon check out what the physical therapist is like. The place that they tell you to go to, they may have never had any contact with, or you just go to the place that's geographically close to you. As a trained dancer, I knew all about my body, but I had the ability in my mind to do a lot of exercises, but I only had so much ability to deal with so much pain. So I'm just saying the type of physical therapy that is out there varies immensely. And if the doctors really knew what the PT people were doing, there might be a better match.
wrap this one up and then move on to the next case. But hopefully you guys all get the message that, patient input is really important. You need to work with the patient for your treatment plan, and also you have to communicate with other professions, because you can't just send patients over somewhere and you don't actually know what's happening there. And also the social support and all the other aspects of the patient are all important.
Out there, because we didn't really touch a lot on the pharmaceutical aspect of this case at all, but when I read this case, I came up with like a huge list of questions that I would want to ask this patient about their medications. And especially like one thing that really stuck out to me with this case is having scheduled pain meds versus PRN pain meds, because there have been multiple studies that have shown scheduling NSAIDs or acetaminophen is more beneficial than using them as needed, because it's kind of like the catching up versus the staying on top of it whole concept. So that's something that stuck out to me as a pharmacist. But there were like a lot of other questions that I had, like they've tried over-the-counter NSAIDs, but those aren't as strong as some of the prescription NSAIDs, so I think that might, offer a little bit more pain relief. And then I'd also want to know about, ruling out any possibility of having possibly nerve pain after all of these surgeries, related to the type of pain that this patient is experiencing, because they might benefit from medications like Cymbalta or Lyrica or something like that as well. So I just wanted to make sure that pharmacy wasn't forgotten, because when I read this case, I was like, oh, well, he's only tried like 2 things, so maybe they weren't all listed on there, but those were some questions that I thought of.
All right, very good. All right, so now we move on to the second case. I don't know if you guys already got that one yet. Hopefully you got enough time to discuss this case. All right, again, we need one volunteer give a very brief summary of the case.
The summary of the case report. Does anyone want to tell us about it? Quick one.
So he's a 60-year-old male. He's 6'1", 215 pounds. He complains of various chronic musculoskeletal complaints, low back pain from 5 herniated discs, PTSD, and scar tissue accumulating in the left hemisphere of his brain. He's had a lumbar compression fracture, 5 herniated discs, bilateral torn Achilles tendon, and a ruptured tympanic membrane. His immunizations are up to date, and he's prescribed alprazolam for 50 milligrams for sleep. Over the counter, he takes niacin daily, L-citrulline for PTSD, 50 milligrams twice daily. He's got a key flex relaxation. In 1976, he was an inpatient for a psychiatric evaluation due to physical and mental trauma in the Navy. He exercises 4 times a week with weight training, biking, swimming. It has been his go-to when the pain of onsets. He's now doing equine therapy, which has been helping. He tries to sleep on his back. Usually he's in pain during sleep, though. There's been a delayed onset of sleep from but the olazapam helps, and he suffers from nightmares and only gets about 3 hours of sleep for the past 30 years.
Open it up, and if this patient walk into your office, what are you going to do?
So we had the patient at our table, and we asked the question, how do we balance treatment with seeing someone as a whole person? What's the strategy we can use? And the answer was asking the right questions. For example, asking the patient, what are you passionate about? And his answer was he's passionate about horses. So the equine therapy seems to have been something that, it wouldn't be my first line of treatment if I was, not asking you the right questions. So there was that, and also we talked a little bit about, or we're thinking a little bit about how asking these kind of questions kind of might be a little bit strange for us as we've been working on our focused visits and like staying very focused on one symptom and accomplishing one thing in this appointment. And it can be difficult to take a step back outside of that tunnel vision, so.
Thank you.
about the medications? Anybody want to chime in on that aspect? Or managing his PTSD?
Medications, I don't take them. None of them. I won't. You could offer them to me and I'll refuse you. I took medications through the VA for about 6 months, and it left me drooling. It left me incapacitated, and I won't touch a drug. If I touch a drug that has any effect on me, and there is one, but doctors don't prescribe it, it's more of an emotional, psychological. I have a mental illness. I'm mentally ill. You can all nod your head and say, yeah. Because when you have PTS, you're labeled as mentally ill. So I decided, why not take lemons and make lemonade? Why not get trained in the mental health field as an intentional peer support navigator and a NAMI facilitator and a suicide assist trainer? And that's all I work with today is veterans on the verge of suicide, like today. Yes, I do work with horses, but that has to do with my nervous system. What? Nervous system? I play cello, has to do with my nervous system. I meditate, has to do with my nervous system. Anything outdoors, the environment, nervous system. Why the nervous system? Well, doctors are going to cringe when I say this, but I have a Bendikeric brain center, and my brain injury is extremely severe, where they gave me about 2 years to live, and I've gone past that. So they cringe because I tell them how I feel, and what I say is like this. I have found new things in my life that I did not expect to come into my life that I'm passionate about, things I never would have expected myself doing, like playing cello and playing Bach in the field to my horses, or meditating with my horses, or introducing dozens and dozens of veterans to my lifestyle, including burst strength training, which thank you UNE, because you introduced me to it. I've been working out all my life, but the burst strength training balances my cortisol levels. Thank you again for that. No drugs involved. But again, they cringe when I have this discussion around the country and I talk about my nervous system because of my brain injury, where I've had a lot of treatment at Carrick Brain Center in Texas because it stimulates my neurons in my brain. And if I stimulate the neurons in my brain, neuroplasticity is a beautiful thing because my brain starts to help itself. It starts to repair itself. So should I continue to do these passionate things? Should I continue to let my brain heal naturally without the drugs? Am I mentally ill? According to society, I am. I'll always be mentally ill. It's a form of discrimination. It's a stigma. Thank you. I'll carry it. And I'll share it with my veteran brothers, and I'll tell them, hey, screw them. You want to do what I'm doing? Fine. You want to find your own path and you want to own your own path? Fine. I don't know what else to say.
No, we're short on time here, so maybe we'll have the panelists give us some more comprehensive management for this case. Just anything you can think of, because we're wrapping up anyway.
Well, the thing that stuck the most out to me in this case obviously was the medications, because that's usually what I'm looking at as a pharmacist, and 50 milligrams of alprazolam would be about enough to pretty much tranquilize any person and probably elephant. So that was like the thing that stuck out to me the most, was that dose, and it's probably a typo or something. And also I would address the fact that I probably wouldn't choose a benzodiazepine for a patient with PTSD in the first place, even if it is for insomnia, because it's actually contraindicated in patients with PTSD. A, they're at a higher risk of substance use disorder, and B, it actually interferes with the cognitive behavioral therapy that they would get to treat PTSD, which is actually really, really effective. But benzos work by basically like numbing your feelings. So like they're a really good coping drug, but they don't help you cope effectively in any way. And so they kind of make you feel numb all of the time. And So the way that they treat PTSD is to make you re-experience what your trigger is almost. And having a benzo on board prevents you from being able to have that re-experience. And so that's why it's contraindicated. So those are like the things medication-wise that stuck out to me. But as the patient said, he's not actually taking medication, so that wouldn't be a huge concern.
I guess the only thing that I would add to what you just said is the piece about cognitive behavioral therapy for folks with PTSD, that that's only one kind of treatment for PTSD, and I'm not sure that that is the be-all and the end-all, and I think what a lot of clients that I've talked to who've had cognitive behavioral therapy have said that it's a really great start. It helps them to develop some coping skills, but it doesn't address the trauma. It does not. It doesn't address the trauma.
What they said, and I cannot overemphasize the importance of the language you use when speaking to people about this. I actually have a whole spiel that I've developed on the subject of trauma and pain, and it's literally trauma spiel, and my brevi will automatically trigger the paragraph to appear in the note. It's super important that you make clear, as this gentleman did, you're talking about your neurology and your brain. You're not talking about all in your head. When you start down the path of conversation, that there may be a kind of therapy that can help you, there may be a counselor you can work with, it's important for you to engage in meaningful activities. Many people, especially those who have been trivialized in other areas, and bear in mind there's significant gender and racial stuff along who gets good pain management to begin with, so there's all that on top of the pile. It's very important that, the first thing many people say when I introduce the subject of CBT or EMDR or whatever it is, what, are you saying that this is all in my head? Are you saying I'm making this up? What's a therapist going to do? Is a therapist going to put my spine back together? And you need to be more than meeting them halfway on the subject of no. But when you have chronic pain, you have tremendous loss, you have tremendous change, you have tremendous amount of work you need to do, and there are counselors who can help you with that. But the language is super important, because what people will hear, and what they've probably heard from people at home and people at work, is that their pain isn't real. And I always make, no, you have real anatomical pain, but some of this is going to be about training your brain to experience it a different way, not make it go away. This isn't mind over matter completely. This is literally changing your brain's experience. But have that elevator talk and have it ready before you lay it out on a patient, because it's a very long and winding road. I can't say enough good things about what you're saying with benzos, because I have so many people who come to the methadone clinic on 5 Xanax a day, which is a good way to die if you're mixing it with methadone, to the point that we have a little standard letter that we give to the prescriber saying, hey, dude, if you could get this person off your ton of Xanax, that would be terrific, love me. But additionally, yeah, it's people even use, well, I have PTSD, like it's their ticket to benzos. And actually, I always say, well, that's all the more reason that you really want to avoid this class of medication. I wanted to add one more thing, and that conspicuously absent from the history that I'm hearing people is, do you have a family member with a substance use disorder or a psychiatric, and I always say psychiatric diagnosis or substance use disorder, saying that ever your parents have a problem with alcohol or a mental illness is stigmatizing, and it's not, they may not even think of it that way. Having a parent with a substance use disorder informs both your biology and your trauma history, and it's a really important thing when you're considering a controlled substance, because your risk for having a substance use disorder yourself, even if you didn't grow up with the affected parent, is 50% increased if half of your DNA comes from someone with a substance use disorder. So don't ever forget, like you'd be and you say anything run in your family, and people will say cancer and heart disease, because that's what runs in everyone's family. What they won't say is, yes, my father was an alcoholic and I was terrified of him. So you have to ask. If you don't ask, you can't find out. But that's a really, really important part of the history that I really haven't heard discussed much.
I just got one comment, one kind of closing statement. Living with chronic pain, we go to all kinds of different doctors through our life. Been wearing my brace for 16 years. I see good doctors and I see bad doctors. And hopefully things like this, we are turning into some good doctors. Thank you.